today to talk about the American Psychiatric Association's take on gender dysphoria, sexual dysfunctions, and paraphilic disorders. Now, those are three different areas in the DSM-5, not to be confused with each other, but I feel like kind of fall in some similar realms there and are short enough sections where I like to put these together and talk about them together. To be clear, this is coming from the DSM-5 released in spring of 2013. Okay, let's get moving here on gender dysphoria. Now, this was what we used to call gender identity disorder, and the DSM-5 has a couple of different sets of diagnostic criteria for gender dysphoria. We have one for children and one for adolescents and adults. So we'll talk about each of these. I think what we have to say very loud and clear from the beginning is that, well, first of all, it's important for APA to get away from the terminology of gender identity disorder and go towards gender dysphoria, because I think they wanted to take the emphasis off of the problem for gender identity issues being around how the person sees him or herself. Okay, so in other words, it's not the problem as far as APA is concerned is not that you have, let's say, a biological boy who feels like a girl, or a biological girl who feels like a boy, or a man feeling like a woman, or a woman feeling like a man. That isn't the problem. The problem is the incongruence and conflict experience between your biological assigned gender and then what you experience and feel in your heart about yourself. It is that dysphoria, it's that conflict that you have with yourself. And as a social worker, I think I just need to go a step further and say that the issue is as much about adapting to society as it is about adapting to oneself. I think, for a lot of people who experience gender dysphoria or any kind of gender confusion, and maybe they wouldn't even describe it as dysphoria, that as far as they're concerned, he or she is concerned, it's not an issue that they feel this way. It's just the way that they feel, and that the problem is that other people and the way they treat them. And we all, I'm sure, know. The issues that we've had in our society and our cultures around same-sex attraction, homosexuality, around sexuality and gender in general, and then now with gender identity types of issues. It's not been an easy road for people. And so, of course, when it comes to faith perspectives and it comes to cultural expectations, those are all different topics. So I'm not here today to talk about and debate, right or wrong, moral, immoral, God's will, not God's will. I'm here just to present this from the perspective, from a clinical perspective about what we see in the DSM-5 and sort of how APA is recommending that we think about this. And again, I think from that sort of psychiatric perspective, and then taking that with the social work perspective, systems perspective, knowing that what people struggle with is sort of that internal experience, and then how to adapt that into your relationships and into your community. And so obviously something like gender dysphoria is going to be a really, really big issue for most people in terms of finding community support and encouragement and acceptance and all of these kinds of things. And so I would certainly say that on the part of APA, and then I think the way that we want to talk about this from a clinical perspective is that this is about as much about adaptation as it is about right versus wrong, or what really is happening here. A lot of people are surprised to find out that this is a disorder that we really see, or these are issues rather that we see coming up in childhood, early childhood a lot of times, and has mostly to do with gender, and of course prepubescent human beings, also known as children, are maybe aware on some level of gender differences and even sexual preferences, but that's not a strong impulse at that point. That's not a strong instinct at that point. And so the issue in children, and what you'll see is much more discussion of gender and gender preference, gender insistence, how we like to play, what do we play with, who are our playmates, And anything sexual has more to do with just not liking one's own anatomy or just physical sort of development there. And so that's something to kind of keep in mind, that at those early ages, that what we're really talking about is long-term, persistent. This is not going away. It didn't come up suddenly, and it's not going away suddenly. And it's just a long-term, insistent. It's not just a preference either. I mean, I think there probably are a lot of young people out there who might struggle with some of these thoughts and feelings, but it's not such a powerful impulse that they cannot sort of overcome it. I think when we see it at this level, we're talking about somebody who just cannot think of themselves any other way. That inside of themselves, when they think of themselves, they think, okay, I'm biologically a boy, but I know deep down inside that I'm a girl. And that's what we're really seeing with gender dysphoria in children. And then, of course, in adolescents and adults, you see this going on, that this continues. This is not when it first comes up, but as you might expect, as we're going along here, that there's going to be the addition of the actual sexual preference. By the way, just because you have a biological boy who feels like a girl, that doesn't necessarily mean that person is going to favor men sexually. And so we have to be very careful about not making any assumptions related to how somebody's experiencing either their gender or their sexual orientation. Okay. But again, you have this strong preference to the point of insistence of being the other gender and dressing that way and being treated that way. And again, the impairment has to do with adapting to community. I should say this, I think the dysphoria, I mean, it could be that somebody's very disturbed that they are having these experiences, that they don't like that they're having these. But again, I think we want to be careful not to assume that somebody is distraught because they're having these experiences, when it could be that they're just more distraught by the fact that they know that as long as they're doing that, their parents aren't going to accept them, their family, their friends, workplace, all these things are going to be big problems for them. Okay. And then the APA tells us, make sure that you are being very careful to specify if there's a disorder of sex development along with that, if the person is doing any transitioning, surgeries, gender reassignment kinds of things, and all that. Some other things to think about: nonconformity to gender roles, transvestic disorder, body dysmorphia, and then of course you want to rule out that the person isn't sort of having any kind of psychotic experience within themselves. You would never want to assume that they are, but that would be something to think about and make sure that it's not happening there. Okay, so that's kind of what APA has to say about gender issues and gender dysphoria. Let's move on to the sexual dysfunctions. Here we get into an area that affects all human beings who are post-pubescent, and we know that sexuality is pervasive. It's something that all humans are going to experience on some level, in some ways, maybe with very, very, very rare exceptions. As social workers, this is an area that we can't afford to shy away from. I think, in my own practice, it's never the thing that I focus on, but I know that if I don't get around to questions around sexual functioning, that I'm missing a potentially very important area here. So what are we talking about here with sexual dysfunctions? Partner factors, we're talking about relationship problems, we're talking about vulnerability. There could be some psychiatric stuff going on there. There could be some sensory things happening there. Of course, we know that there could be some trauma. There could be some early life experiences that have made sexual expression incredibly uncomfortable for people. There could be a lot of cultural and religious factors. Some cultures and religions are very inhibited, others are completely prohibitive. And others are more like, hey, whatever feels good, and kind of go do whatever you think. And then, of course, there are just medical factors. There are people with, erectile dysfunction, or they're having problems with any kind of response. APA recommends that we think about sexual functioning as a process, and I will frequently use the analogy of flying an airplane. And if you've ever flown, then you know that there's a kind of a nervous moment in the beginning, and then the airplane takes off, and you want to see a nice smooth takeoff, and then of course it gets up to altitude, And now we're talking about desire up through excitement, and then you get up to altitude, and at some point you're as high as you're going to get, and here we're talking about orgasm or the peaking of sexual pleasure, and then resolution, a nice safe landing, which, by the way, I must say that in my clinical work, I think the resolution part can be where a lot of problems are for people, especially if they are struggling with any kind of trauma history or any kind of religious, moral kinds of issues around sexuality. Maybe they spent their whole lives being told that sex is bad, it's forbidden, and it's dirty, and it's whatever. And then even when they find themselves in a situation like marriage, where they feel like I'm now in the clear. God, it's God's will for me to engage my partner in this way. It's like they spent so long feeling bad about those thoughts and feelings that they couldn't just sort of flip the switch on that. And so that resolution thing can be a really, that should be a time of muscular relaxation and general well-being. But for a lot of people, that might be where they start feeling guilty and feeling dirty or feeling whatever. That can really affect that whole process there again. So I tell people, what we're looking for is basically we want a nice, smooth flight. We want a nice, steady takeoff. We want, to get up to altitude, and then we want to come down very safely and smoothly as well. And that's what we're kind of looking for. And if you've developed a rapport with your clients and you're talking, through that whole process with people, if you're going to find problems, you're going to find problems somewhere along that sort of trajectory. And what could you run into? You could run into a lot of what APA talks about. For males, delayed ejaculation, or the opposite, erectile disorder, so somebody who's not able to physically respond. Female orgasmic disorder, so for women who just cannot bring themselves to have an orgasm. Female sexual interest or arousal disorder, so women who just don't have the interest or arousal going on there. Some people just have a lot of pain when they have intercourse. They have the male hypoactive sexual desire disorder, so that's a man with the low sexual desire, and then premature or early ejaculation, which would be one of the easier issues to work with people. Mostly that's an issue for men. And then you just specify if it's generalized or situational, if it's lifelong or acquired. This should say mild, moderate, or severe. Okay. And those are the sexual dysfunctions, and again, I think the point of talking about these issues is just that, again, we need to make sure that we're not shying away from these conversations because they might be so personal or uncomfortable. For a lot of people, this is where they're experiencing a lot of conflict and a lot of, when it comes to cognitive therapy and cognitive restructuring, a lot of how people see themselves, or, a significant portion of how they see themselves could be attached to their sexuality. Okay, and so we would want to treat this very carefully, very responsibly, in a very client-centered way. But I think, but make sure that you're not shying away from those conversations. Okay, this is going to be a very rocky transition, an awkward transition into the paraphilic disorders. This is a different chapter. There's a whole different deal here. So I don't mean to go from, general sexual functioning right into paraphilic disorders. Here we're talking about really intense, dysfunctional, distressing, impairing, disturbing sexual urges. Okay, so the paraphilic disorders are, you see at least 6 months, recurrent, intense, and persistent sexual arousal that are acted upon that may or may not include a non-consenting person. This is for people 18 years of age and older. It's causing a lot of distress and impairment, probably could get the person in a lot of trouble. And you'll see why here in just a minute. And then you specify if this is in a controlled environment or not, as in prison would be an example of a controlled environment. Here we're talking about voyeuristic disorder. Here is when somebody wants to view other people in the act of sexual intimacy. Exhibitionistic disorder, somebody who wants to show themselves off. Frotteuristic disorder, this is somebody who goes into public and rubs up against people, so it's unwanted, unsolicited sexual contact in public. And then sexual masochism disorder, that's somebody who likes to be hurt. They get sexual satisfaction out of being hurt. Sexual sadism is when they want to hurt other people. And they get sexual satisfaction out of doing that. Pedophilia, which is child abuse. And then fetishistic disorder, that could be, any fetishes can range from, well, it could be anything. It could be animals, it could be shoes, it could be clothing, it could be, makeup, it could be anything that a person would just attach inappropriate sexual interest to. And then transvestic disorder, we want to be very careful here to differentiate between what we think of as a transvestic disorder, which would not be illegal or necessarily a problem. Some of these are like fratourism and pedophilia and exhibitionism, obviously are things that could get a person into a lot of trouble. With the transvestic disorder, you have somebody who's getting sexual arousal out of dressing like the opposite sex. That would be different from a gender dysphoria disorder. You could have somebody with gender dysphoria who engages in transvestic behavior, dresses like the other, but they're doing it more for gender purposes. When we're talking about a transvestic disorder as a paraphilic disorder, we're talking about somebody who's actually getting sexual arousal from doing this. So we want to be very careful to not lump somebody who's getting sexual arousal from dressing as the opposite sex with somebody who actually prefers to dress like the opposite gender. Okay, so that's a very quick sort of rundown of the paraphilic disorders. A couple quick things I need to say about paraphilic disorders before I end here. One is that they tend to follow a very similar course as the impulse control disorders. In other words, we see somebody with like an increasing tension and arousal, and then the behavior becomes very compulsive and impulsive. Like they just kind of can't get it out of their heads, so they're going to act out on this, and it's behavior that gets away from the person. So there is this sort of out of control feeling with the person. And of course, if you're doing things that are going to get you arrested or that are harming other people, then we know that there's something really wrong there. There's something that's really there's a lot of either pressure there or a lack of empathy, similar to what you might see with like an antisocial personality disorder. So there are a lot of things that we wonder about related to the paraphilic disorders that we want to really look into. I guess it would probably be somewhat unusual for them to not have evidence of some other kind of either impulse control disorder or a personality disorder. Okay. All right. Well, that is it for now. Thanks for tuning in. She says, wait.